to the third session of CCA's webinar series. As we all know that today's session focusing on the theme, right to health amidst COVID-19 crisis. This is another effort of CCA to discuss on one of the most important issues in the context of this unprecedented crisis of the global pandemic we are facing now. The COVID-19 presents an overwhelming public health challenge, but it became inevitable to address certain long simmering concerns related to the right to health. So the spread of this novel coronavirus has affected people's health, their freedoms, and their livelihoods. And also it is triggering a global human rights crisis. We know that the right to health is a fundamental part of our human rights, and our understanding of a life in dignity, or in Christian theological terms, if we put it, life in its fullness. So the right to health was first articulated by the World Health Organization in 1946 itself, when the WHO came up with its constitution, where it stated that the enjoyment of the highest attainable standards of health is one of the fundamental rights of every human being. And subsequently in 1948, when the United Nations drafted the Universal Declaration of the Human Rights, so the UDHR also very clearly stated about right to health as a basic or a fundamental human rights. For example, it was articulated in Article 25 of the Universal Declaration of the Human Rights that everyone has the right to a standard of living adequate for the health and well-being of himself or herself or their families, including food, clothing, housing, and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihoods in circumstances beyond his control. So the right to health was again given more prominence, and also it was recognized as a human rights in the 1966 International Covenant on Economic, Social, and Cultural Rights adopted by the United Nations. So today, when we compare the situation being emerged due to the COVID-19 crisis, we know that there are innumerable instances and examples of violations of right to health and right to health and right to life, especially when the basic necessities of life, as it is stipulated in the Article 25 of the Universal Declaration of the Human Rights. So understanding health as a human rights creates a legal obligations on states to ensure access to timely and acceptable and affordable health care for all with appropriate quality, as well as to providing for the underlying determinants of health. In many cases, the right to health has been adopted into domestic laws or even constitutional laws and constitutions of several countries in the world. One thing is very clear, that the right to health must be enjoyed without discrimination on the grounds of any race, age, ethnicity, or any other status of a person. But if we examine the right to health in contemporary situation of COVID-19 crisis, we realize how much the scale and severity of the COVID-19 pandemic clearly rises to the level of a public health treatment. And it has become a public health threat that could justify restrictions on certain rights, such as those that result from the imposition of quarantine or isolation, limiting freedom of their movements or restricting their freedom of movement in different ways. So COVID-19 has now been confirmed in more than 206 countries and territories in the world. This is according to the World Health Organization statistics and reports. Neither rich nor poor have been spared, and the death toll, a number of people testing positive for the virus is rising every day, every hour, every second. So in this context of a spreading epidemic states, as well as civil society and faith-based organizations have obligations to ensure the preventive care, then treatments, goods, services, information are available and accessible to all persons. This is the responsibility of everyone. Government, civil society organizations, faith-based organizations, all are actively participating in efforts to combat the spread of COVID-19 and to provide assistance to the infected people in their respective communities. At the same time, there are a wide range of criticisms and concerns that government's responses to the crisis have included sweeping restrictions on limiting, restricting, or negating the right to health of people in many contexts, including restricting their freedom of movement, as I mentioned earlier. It is in this context that this webinar examines issues related to the right to health amidst COVID-19. And the presentations and the discussions of this webinar will be focused from different angles. Here we shall get various perspectives from the global public health policy perspectives, especially from the perspective of United Nations related intergovernmental mechanisms, church and ecumenical organizations, especially those who are concentrating on health-related issues and healing mission perspectives, then civil society and faith-based organization perspectives. So in order to share various perspectives and experiences, we will have 7 panelists with us, and they will be sharing different perspectives and experiences through 5 segments of this virtual conference. And the segment 1 will focus the COVID-19 crisis and the emerging challenges to health and well-being of people. And the second segment will cover on right to health with raising a question, a myth shattered by COVID-19. And the third segment will focus on responses of the network of Christian hospitals and health services in Asia. And the fourth one will be advocacy role of Asian churches and non-governmental organizations towards upholding the right to health amidst COVID-19. And the fifth one will focus on how churches and NGOs are addressing the issue of mental health of people amidst COVID-19. Well, towards the end, we will have some time for questions and discussions too.
Right in the beginning, the right to health is crucial in these days of the COVID epidemic and response. And when we use the word right to health, it means more than just right to health services. It means right to determinants of health, right to various freedoms, entitlements, and absence of discrimination. So we take that kind of approach to what is right for health. It's just not right to what is provided in a health center or hospital, because all the other determinants are very important. So now, before I address this question of this particular session, which is what can governments do and what can people and communities do to advance right for health, I would like to introduce myself as representing an intergovernmental agency, the UN system, and particularly the joint program known as UNAIDS. UNAIDS is a joint program consisting of 13 UN agencies. You could think of from WHO to UNDP to the all development partners in the UN system. And we target the AIDS response in general. And as of now, to inform you, the whole UN system is now being kind of rewired to address the COVID epidemic. And the UN system is looking at it in three broad streams, if I may use the word. One is the health stream, which is, of course, we are basically concerning that now. But there is, in addition, a humanitarian stream, and then there is a socio-economic stream. So I will confine my talk now to the health stream, and in the context of UNAIDS and our co-sponsors, 13 UN agencies. And I would start by saying that our experience in dealing with HIV epidemic is very relevant as we deal with the COVID epidemic now, because of many reasons, but mainly I would talk of two reasons. One is the multi-sectorality of response, because the COVID response cannot be just health sector. It has to be whole of government, whole of society response. So the multi-sectorality is important. The other one is the role of communities. Communities are key in getting the response on track and demonstrating results. So let me now go straight to the questions posed to us in this session. What can governments do? First thing I would say is the governments must realize that this problem is here to stay. There is no way that you can see the end of it in 3 months, 6 months. Most experts think it is a horizon of 18 to 24 months. So that is the first thing that I would like to come as an intergovernmental agency. What can governments do to realize the scope of things over a period of time? The second is it has to be an all of government response, whole of society response. It cannot be just the health ministry or hospitals and so on. And the third one, the point that I would like to make in terms of government's responsibility is you can never over prepare for this epidemic. We started off underprepared, we are prepared, but we need to continue to equip ourselves in terms of commodities like PPEs and drugs and things like that, and also people, the human resources. So we cannot be over prepared. We need to continue to prepare and do well. And the next point I would like to highlight is, while doing this, we should not forget other illnesses, other emergencies, other medical emergencies. You know, as of now, we see a phenomenon where all hospitals are looking only at COVID response. Beds are reserved, ICUs are reserved, OPDs are reserved, waiting for a deluge of cases which may not occur in many cases, right? So we need to be prepared for cardiac arrests and other emergencies that may come to hospitals, not to refuse them and treat them. So that is something which needs to be very clear at the government level. Next point is I would look at, we cannot assume an one-size-fits-all approach. We should, to the extent possible, localize the response to the context. What is happening in the West is different from what is happening here in this region. We can see it already. In the West, it is people, most of the deaths are in people over 80 years of age. That is because they have this old age homes and nursing homes, which is not part of the culture in this region. So the profile will change in terms of people who get infected and people who die. And we have, in our context, good examples. Like you can see Vietnam is an example. You can see the state of Kerala in India. So use good examples from your own country or from this region to inform your response. And then in terms of government advice to governments, managing lockdowns is important. How do you do lockdowns? Lockdowns cannot be purely law and order kind of thing. We should have communities involved, and there should be respect to human rights when we talk of implementing lockdowns. That is the lesson we have learned over the last 3 months. Coming to communities. For communities, as people, need to be partners in the national effort, because just the governments and government machinery cannot do this alone. And that is crucial to be partnering. And I would end with the extreme importance of stigma and discrimination. And that is where communities are very, very important. We have seen examples where healthcare workers cannot go back to their homes. We have seen examples where airline pilots and others who work for us when we are safely at home being discriminated at their homes and in terms of their access to various social services. So communities and people can play a big role in addressing the stigma and discrimination against people who are either infected or people who are serving these COVID patients. And finally, there are some good resources that the UN system has come out with, and I think that is going to, I will share them later, especially human rights in the time of COVID. There are statements from the Secretary General of UN, of the United Nations, and from the EXD of UNAIDS in terms of maintaining human rights at this stage of the response to epidemic.
Topic for this segment, the second segment, is looking at two things mainly: the physical and the mental well-being of a person. Both are very solid and holistic words. Words that are important and words that have been ingrained into us as we serve in the mission. CMAI represents healthcare institutions which have a Christian identity and are regarded as mission hospitals. And of course, we are part of a wider Christian healthcare networks within our country as well as globally. The uniqueness of our hospitals, our member hospitals, are that they are primarily in resource-constrained settings. So when we talk about a holistic approach in this kind of a crisis, what have our mission hospitals done and how are they reacting, and what is the support that the government is getting, government is giving to them and they are giving to the government? Because I think it works both ways in a crisis like this. The hospital first. Let me paint you a picture. Picture the hospital that has been there for decades and in some cases for centuries. The hospital is standing, the hospital is available, they are open to the public, they are committed, just like the stoic missionaries who came in and started those hospitals. Those corridors and walls will stand for commitment and for sacrifice. Our hospitals are open and they are willing and ready to serve the public and their community in this time of crisis. So what have they been doing? Before the surge has come in, there was a period of lull because, as Dr. Mathews mentioned, and there is a lot of lockdown has created patient footfall has decreased because there's no transport and supply chains have gone, the revenue streams have been blocked. So there was a lull, but our mission hospitals were very active. What were they doing? They were getting themselves prepared. They were making their own masks. They were innovating. They were sharing good practices with each other as to how to sterilize masks in a resource constrained setting. They were learning from each other. They were congratulating each other. They were getting prepared. And that is something that the community saw. Now go on to the community around the hospital. Many of them have little towns which have grown around the hospital. Some have bigger cities. Let's look at the community which is now coming to those hospitals. They come knowing that the doors are open, number one. Second, they know that the doctors and the healthcare staff are all looking out for their protection. They are provided with masks, the families get masks, the security guard gets masks, everybody is protected. They have built their trust in this hospital and the hospital has not failed. They are not limiting themselves to the hospital boundaries. They have gone out, the healthcare workers from our hospitals, and distributed rations to their community. And they have the list. They know who requires the ration. And they have gone in a very structured and strategic way and helped those communities. They have provided home-based care by understanding the importance of caregivers in the home. They have ensured that they're available on the phones, and for that we thank our government for ensuring connectivity in remote parts of our country too. So that is a big advantage. We have the hospitals maintain a database so they're able to know who needs the help. So they have ensured that the chronic care is given despite the lockdown. And as Salil was pointing out, the importance of the community. Awareness generation and education in a time of this COVID has been done. It's slowly picking up, especially among our hospitals, which already have a strong community awareness and outreach program. So that has been done. So the hospital is ready. They've reached, the community knows they have the trust and they are able to access all their needs with respect to their physical, their mental, and their social needs. Support. What is the support that the government is given? Because that's an important part of this question. The government for the health worker has provided 5 million per health worker as an insurance cover. So that is something which is very, it's reassuring for our health workers because there is a lot of fear, there is a lot of anxiety, especially for the family of the health workers. They have come up with, there are government schemes and national, both national and local, where probable operational and patient cost can be reimbursed. We are really pushing for that. There is from networks as well as from CMAI, we have set up tele-counseling and probable telemedicine kind of platforms for ensuring support extended to the community. And of course, another very important support from our network of healthcare healthcare networks is prayer. There is a lot of prayer going on. There is a lot of encouragement. There are devotions. There are constant sources of encouragement for the health workers in the front line, as well as those who are trying to support them from the back. There is an absolute strength that is seen in this kind of spiritual fellowship, and each of them advocating for each other. And here I'd really like to mention the support of EMFI, ICMDA, the CCIH, and so many more who are so tuned to helping Christian healthcare networks across the different countries. And they have been very forthcoming in their support and giving us advice and opening up doors for opportunities. So in relation to the first topic of physical, mental well-being, yes, our hospitals are looking at it in a holistic way. They are making do with what the resource availability is there in their remote locations. They are looking to the government, and the government is responding in different ways. And of course, the networks are holding up each of them in prayer. It is a difficult time, there's no doubt about that. And as CMAI, we are trying to do our bit too.
I think COVID-19 pandemic crisis is not just impacted for the poor and the vulnerable people, because this pandemic impacted all of the people, the poor, the rich, all is impacted. Then everybody suffering to attain for the highest standard of the health. Why? Because the lack of readiness of surge capacity in healthcare. Because in Indonesian context, we are not ready with the isolation room, with the system. So we have to do the surge capacity. And we don't have enough time to prepare for the surge capacity. But I think the Indonesian context, Indonesian government tell about this as a pandemic in Indonesia. So they take responsibility for the treatment and the social impact of all the people. In Indonesian context, the government pay all the tests, pay all the treatment, and pay for the social support for the poor and the vulnerable. I think it's a good step for the Indonesian. And also, we talk about the lockdown. Indonesia, there are no lockdown. Indonesia, we have a limited social interaction, or the big social interaction. We are limited. So the economic tire, the economic gear still running. Some of the shops still open. The industry in certain areas still working. But with the physical distancing, with the campaign of hand washing, and also they are not allowed to make a big meeting with close relationship, then I think it's good. You see Indonesian number for the COVID-19, it's only 15,000-16,000, and we have 260 more millions people. We have only 15,000 COVID. I think Indonesia has make a great policies in dealing with COVID. Even though we have a very limited resources. For further, we are talking about the basic right to health. Yeah, I think the government should have to consider some indicators in terms of basic right to health. First, I think what we think is the community knowledge and preparedness. Just knowledge and how they do for preventing COVID-19 spreading. It must be measured. Because community take role, not the medical team take the role. I think the first to take the role is the community, because they can prevent the spreading, not the medical team. So the focus should be not the medical team, but on the community knowledge and preparedness. And second, what the indicators should be considered is the health protection and COVID-19 prevention policies and tools provided by government. Because in the surge capacity, we lack for some facilities. And we have to pay a lot for the mass screening for the COVID-19. But the government provides this. In Indonesia, not so many people do the mass screening. The standard should be 20% of the people, but we still 2 to 3%. But I think it's getting more and more because in Indonesia now we have many machine for the testing, PCR machine, and I hope the mass screening can be done. And then we have the government should have quarantine facilities because not everybody can be quarantined at home because of the situation, and also sufficient healthy nutrition. That's the second. And the third, we have to talk about the qualified healthcare facilities for treating suspected COVID-19. If we talk about the qualified, we have to talk about the competence of the human resource to manage the diseases. We have to talk about the equipment and the medicine. This is the indicators about the readiness for the basic right to health. And the fourth is a social and economic support, especially for the needed community most impacted by pandemic policies and pandemic situation. Because even we have no lockdown, but I think many people also have declining for the income, and they have to struggle for several months before it getting better. I think the curve, the peak of the curve will be passed, and then we can go for the declining. But after this, but I think we won't be back as normal as before COVID-19. It should be new normal after the COVID-19 pandemic. That's my opinion about the right to health in the pandemic era.
I would like to start by reiterating that the response to the coronavirus is a multi-sectoral response. It involves governments, civil society, health providers, scientists, the UN system, and communities are at the center of the response. Community engagement is one of the key lessons that we have learned from the HIV response. And that this lesson can be successfully applied to the COVID-19 response. Governments must support and empower the communities as key partners to enable them to deliver services to most vulnerable people, women, children, the elderly, LGBTI communities, people living with HIV, and other vulnerable groups. In these trying times of COVID-19, it is critical that services are ensured for people and with the people. That is why domestic investments in community-based service delivery should be a priority for the governments. Also, in such difficult times as COVID pandemic, the governments must prioritize their activities and in such a way as to have an immediate and efficient response. Experiences from across the world have shown that prevention is the best approach to win the fight against an epidemic. And testing should be at the heart of a coronavirus strategy. But it is not enough to test. It is important to also be prepared for isolation, for quarantine, for contact tracing, in collaboration with the communities, with the civil societies, with the faith-based organizations. People should clearly understand the reasons why they are supposed to stay in quarantine, and communities can explain, can deliver this simple message to people. Governments must strengthen healthcare systems to be able to cope with such devastating pandemic. Governments must protect the frontline providers in the response to COVID and prioritize their safety and give them personal protective equipment. To ensure equal access to health, governments should consider removal of user fees for medical needs for the most vulnerable people, because a health system will remain as strong as long as everyone, especially the most vulnerable, have equal access to it. Governments must advocate for protection of human rights so that vulnerable people are not marginalized or criminalized because of their social status, gender identity, HIV status, and so on. So otherwise, these people will fear to seek medical healthcare services. And finally, there is a need for mass education on how people can protect themselves from contracting the virus. Governments can promote healthy behaviors by disseminating accurate, simple messages on protective measures that are easily understood and that everyone can follow. These are some of the measures that governments can do and must do, and I wanted to mention these in order to ensure the basic right to health for all. But of course, governments cannot do this alone. They need our support. They should work in strong partnership with all actors, including the communities and outreach workers, outreach networks, and all citizens, because the involvement of communities is important at every step of the way.
Taiwan has a unique universal health care system. Every citizen contributes to maintain national insurance system. Therefore, every citizen have right to easily access the medical service in any kind of the circumstance, even like the COVID-19 pandemic. In addition, Taiwan has a robust public health system, which is according to Communicable Disease Control Act. Infectious diseases such as tuberculosis, AIDS, influenza, and many others are intensively treated and close monitored and follow up. During the COVID-19 pandemic, those who are home isolated because of the close contact of the COVID-19 cases are monitored by public health officers of their health condition. So the church-owned institute like Taipei Market Memorial Hospital, on the one hand, collaborated and keep the same path with many other medical facilities in Taiwan by maintaining the ordinary clinic service, like the outpatient service, emergency services, and the inpatient service for those who are getting ill. On the other hand, even every major hospital set up the outdoor fever screening station for those who has fever in order to identify the possible cases. The primary medical procedures are carried out in the outdoor station, taking the TOCC, that is the traveling, occupation, contact, and clustering history, the personal history of health, physical examination, blood routine, influenza, and the COVID-19 screening test, and chest X-ray if it is indicated. The most important thing is that the Marquette Memorial Hospital and other hospitals in Taiwan have prepared the adequate numbers of ICU beds and the negative pressure beds for those who are confirmed of the COVID-19 and indicated for advanced treatment in hospitals. So other than about efforts through public education, we also encourage the people to think positively and provide hope and support to those who face the crisis of COVID-19 particularly. the nursing staff and the medical staff and etc. So above is my observation in Taiwan during the past 2 to 3 months. Your inquiry or any question are very welcome and appreciated.
The big one is a Bangkok Christian Hospital, and the second one may be McCormick Hospital, and then is Overbrook Hospital. These 3 hospitals is a big one, so you can do anything for treatment. They have negative pressure room, ICU, and many good personnel in the hospital. And Bangkok Christian Hospital Nakhon Pathom is just that smaller. And another for Priya Christian Hospital, Bantan Hospital at Lampang, and Priya River Christian Hospital and McCain Hospital is a small one. And so they made the grade for the treatment. For the government, I think that it's thank God we have a good government now. We had the war room for COVID. And later leader is a Prime Minister, Prayut Chan-o-cha. So we have the team, that's called Thailand team. So the good team, so we prepare for the treatment, proper prevention, either for in the line. So we can do the protect and treatment in the same way. Now we have today we have an infected patient. It's only 1. Yesterday is 0. No death for 2 more or 3 days. Our hospital in Southern, there are no patient in the hospital. In Bangkok Christian Hospital, we have 8 to 10 patients, but everyone is improved and can go back to home. I will talk about the cooperation and coordination with the Government Ministry of Health, implementation of policy and guideline, and cooperation and coordination in making available hospital space for the treatment of COVID patients. And the second, the medical mission in doing its best to educate people, especially rural communities, ensuring that basic protective equipment is being given to all, medicines and adequate treatment is given to all patients who come to the hospital. Exactly, elderly people are being given special care, and women and children are also. Medical personnel are given adequate training and facility for rest. No discrimination is being made, and free treatment is also given to all patients. Dignity of the patient and respecting their privacy and right to information and good health have been the guide principle, the medical mission. That is what we do for all the patients.
I think this is a very important coalition that was formed in 2013. The Christian Coalition for Health in India was formed to fulfill three basic roles. One was to give a common platform to the health-related churches and programs under the National Council of Churches in India. So there we brought in the Protestant and the Orthodox churches and their own the healthcare institutions owned by them. That was one. The second was the Evangelical Health Association. And the third was the CMAI members of maybe independent churches of under the Leprosy Mission Trust of India and so many more. The Catholic Health Association also came in as a very big, important partner in the Christian Coalition for Health, apart from big medical colleges of both the CMC Vellore and Ludhiana and other colleges. So their role was one, to form this platform so that everybody has one common voice. When we express social as well as health-related challenges emerging from the community and the ground level to the national level. And the third role was to contribute to policies that have come out, that have been brought out by the government in any area, whether it is health, education, ethics, the Epidemic Act also we have contributed to, and any acts which are relevant to our area of work. So this is the coalition that was formed with these three basic roles. Having said that, in this crisis, what has it been able to achieve? Number one, we were able to write a letter as a coalition to the Honorable Prime Minister and express our support, having 1,000 healthcare institutions and about 60,000 beds available for the government as support in this COVID pandemic. Follow up to that letter, our president of the Christian Coalition for Health, who is the Director General of the Catholic Health Association, Father Mathews, had a video conference with the Prime Minister, and it came under the ambit of religious leaders, but that was fine. And he was able to express the challenges that we were facing and get some solutions for it from the Honorable Prime Minister. Follow-up to that was a letter to the Joint Secretary in the Ministry of Health, where we expressed our, we gave information about each of our hospitals, district-wise, state-wise, and what they could, what level of support they could extend in the COVID pandemic. So all that was given to the government, and they have listened to some of our requests. For example, one was we asked for the personal protective equipment to be given. We requested for reimbursement of operation cost for the patients coming in. And the third, we were asked for an insurance cover for the not-for-profit private sector, as well as the private sector, because the first announcement that came covered only the public health workers. So we were able to at least request, please include the not-for-profit private as well as the private sector under the insurance scheme for healthcare workers. That was the other main thing we were able to do, to ensure that our hospitals are able to avail of the insurance schemes, both at the state level as well as at the national level. The Christian Coalition for Health, with the help of some lawyers as well as the IAS officers, were able to draft an MOU to give our hospitals to use as they please at their local level, and ensure that there is some accountability and they get that reimbursement, because yes, they are struggling and the revenue has drastically reduced over this period of lockdown. The other thing CCH is going to be addressing is now the whole vulnerable population of the migrant laborers coming back to their homes. Many of them may not be on that list of the national, to avail the national health insurance schemes. So we are now engaging with the government and with the Niti Aayog to ask whether you can please start including all these workers in those lists, because they might have got missed out, and somewhere that whole middle class section has got missed out. So can the government start broaden that criteria of including more beneficiaries under those schemes, and our hospitals will be willing to offer those schemes and therefore treat the patients and be assured of reimbursements. And even in the reimbursements to our hospitals, we are asking for some relaxations, because some of the rules and the paperwork is a lot, and it cannot be possible for our hospitals at every stage. So that is another thing that we are requesting from the government at this stage for this particular crisis. So these are the main areas where the Christian Coalition is helping. And also it's interesting that among our 6 fundamental rights, the right to health is not there, but we have that's something else we have also advocated for. But yes, so this is the main things that we are doing as the Christian Coalition for Health, under the direction of the Executive Director, Mrs. Anuvinda Varki.
We have 73 hospitals. It's a very little compared to 2,800 hospitals in Indonesia. Mm-hmm. And also we have 21 of the health school and 25 Christian health NGO. And they are all in Bekasi. Now, in this pandemic crisis, we have difficulties because the distribution of the hospitals is not equal. There are more hospitals in Java, but outside Java, in the east part of Indonesia or western part of Indonesia, there are not so many good hospitals. So that's the problem of Indonesia. In that situation, what have Bekasi done? We have Bekasi facilitated a role of member in the pandemic. We ask what the member want to do in the pandemic, and we do the assessment, what they need to do their role, including what medical supplies you need, and we supply like transfer, insulation stretcher, self-protection equipment, rapid tests, mortuary bag, and other equipment. They ask for it. And second, we initiate the alliance between Bekasi and other NGO and the government, like Indonesian Hospital Association, the Association for All Hospitals, PGI, Indonesian Churches, Ministry of Health, and other NGO. We have a coordinate an action to be more efficient. We preventing for the double support for the same thing. So it will be efficient. So we have to take a position not as we only Bekasi do the work, but we work together with the others. And third, we do the fundraising. And mostly, the fundraising coming from the churches in Indonesia, and also some philanthropists. And also, if they want to support for certain things, we do the partnering, the churches or the philanthropists with the certain hospitals or certain NGO. And that's more. We have got almost $1 million for all the project in Indonesia during this pandemic, in coordination with the others. And then the fourth, we support for logistic distribution, because it's not easy to send supplies for all part of Indonesia. But Bekasi take role, because some philanthropists only drop the supply to our office, and they ask Bekasi to send all the distribution to the needed. And we coordinate how to distribute it. And the fifth, we provide media information and education. We make a short film, a leaflet about prevention COVID-19 guide for the elderly, or about the physical distancing, doing hand sanitation, management COVID-19 for the dead bodies, pastoral counseling for COVID-19, and some other things. And the sixth, we provide online media sharing and discussion for hospitals and NGO leaders. We have a WhatsApp group. We have some groups for all the leaders, and we do the discussion and facilitate about the topics. And the seventh, we provide online seminar also about hospital management during COVID-19 and clinical management for the COVID-19.
The coronavirus caught us all flat-footed, especially in terms of preparedness. Although the church was able to issue a pastoral letter indicating, among others, the guidelines and precautions on the COVID-19 pandemic for the churches before it was declared by our government, the enhanced community quarantine or the lockdown, we were able to do that. Following the government's guidelines on what we here in the Philippines called the quarantine or lockdown of sort, mass gatherings, including coming together for worship services, were and still are prohibited until today. This situation necessitated the church to act accordingly as our faith responds to effects of pandemic in our context, particularly in upholding the right to health of the people, the right to life. These responses vary from establishing home worship services in areas not penetrated by technology to using the internet in providing online worship services, to conducting Bible studies and vacation church school in more urbanized areas through internet, to providing food relief to informal communities who belong to the poorest of the poor, supporting community of People's Kitchen to provide food to the communities, and as well as help in cash and in kind to church workers who are assigned to less privileged local churches. As far as programmatic health response, the UCCP has prepared and offered its health institutions, our hospitals, to provide hospital beds to augment the government's effort in taking care of those who contracted the disease. Moreover, through technology, particularly the social media, campaigns for mass testing, information drive on the virus and correct health practices, as well as various updates on the fight against COVID-19 were done together with various NGOs as well as government institutions. All this and more are more than enough advocacy work, as we believe that the best advocacy work is that of actualizing in real life the things that translate into upholding the right of the people to health and life, as all these are interlocking concerns that contribute to the health and wholeness of a person. Today, we are on our second month of the quarantine or lockdown, and there are adjustments made by the government in terms of the kind of quarantine or lockdown being implemented. And therefore, we are challenged. We are faced with challenges, as we all are, the whole world. But here, particularly in the Philippines, we are faced with a challenge, particularly these three. First, the lack of mass testing, and therefore seemingly incomplete data of those who are infected, as well as the difficulty in the task of contact tracing. We seem to fall behind the other countries in doing such thing as mass testing and contact tracing. Number two, more humane implementation of the quarantine or lockdown, as there has been violence, particularly of the common people, in enforcing of such lockdown. There seems to be discrimination against those who have less in life compared to those who have more in life. Number three, as pointed out by our speaker in the previous segment, there's this problem of stigma, not only of those who have the COVID-19 virus, but even of those medical frontliners. They have experienced a lot of discrimination as well. We hope and pray that together as a wider community of faith, we can do more to address the needs of God's people, especially in upholding the right of the people to health and dignity, the right to wholeness, the right to life.
Mental health is very underreported. It is here too in India. The patients who come to the hospital are coming more with a physical issue because that is really taking priority right now. The mental health and the emotional health of the community somewhere might be getting lost. So in order to address this, we as CMAI try to look at platforms which would give us this reach to address like a helpline, the community in general. We tried other helplines, but finally we decided to make our own. And with the efficiency of our chaplain secretary, Ms. Impimenda, we were able to start a tele-counseling service, which is seen on our website. And we are able to address issues from people in 14 languages. So far, the connect has been, the uptake or the response to this has been not very big, but the people who have approached the helpline many of them require repeated sessions. So that is something which is quite important to note. And the fact that we are available and accessible to them should be promoted more, I feel. We also do have a psychiatrist on standby in case there is a much deeper issue to address. So yes, 14 languages, telecounseling services available to address the community needs. Many of our churches, actually, when I asked for counselors from the churches, I got immediate responses. And I really appreciate the churches and the church leadership for doing that, because they would send me the correct names, the correct information, exactly how we asked for it. And there was no delay in setting up the helpline. That I really appreciate the churches for that. A lot of NGOs and the churches have been creating promotional videos, inspirational videos, just videos of them singing as youth groups, as church congregations. I think those also have been doing the rounds on WhatsApp, and somewhere I'm sure those words of the song will reach and touch people. So that's another effort I really would like to bring to the front, the churches as well as NGOs are doing. I have a list from our regional teams. We have a list of about 96 churches who were able to reach out in 3 ways. Either they helped their community, either they helped the hospital, which is close by, or they helped their own congregation members. I understand there was a question about the middle class, and yes, they are suffering because they're nowhere in the, the ambit of what the government is offering, but the churches have stepped up and looked at providing for their own in that group where the sudden revenue crunch has become a huge issue and also affecting the mental health. NGOs have, I know about one NGO that we are working with who have actually their own staff have kept aside money and ration. So, actually funds to provide for those who cannot. So the NGOs are doing their bit. There is a lot of, the government of India, actually the ministry did set up a meeting, a virtual meeting with all the NGOs. They had about 2 meetings, and they were discussing a lot of the social issues. It wasn't so much related to health, but the government is taking interest. They are trying to form working group committees to ensure that every issue is addressed, because somewhere it is their responsibility, and if we can get on board with what they're trying to do, it would be helpful.
Highlight, we make church, making church welcoming and supportive for those with mental health problems. The church as supporter. the need for the church to help people who struggle with mental illness, but like helping someone with a physical illness, the same. The church can help people learn how to live with their illness. Then, to ensure the church to move to more welcoming to people experiencing mental health problems, then starting and growing our church mental health ministry has been and continue to do more. Most people in Thailand don't talk about mental illness. We need to care for them, consider helping in many ways. Peace about mental health, organized support group, offer class to help people learn the warning signs, often information on where to find help, for example, or a page on the church website, and sponsor direct treatment. The positions call for training and credential in psychology, social work, counseling, or psychiatrist nursing. But rather than providing treatment, the direct will trains parishioner to the right place for help. In my church, work through Bible study on mental illness, get some training, pray together. Later to a profession make people with mental illness thoughtful and sensitive. The act of the sharing story with other, sharing grief with other is therapeutic. We are grateful that Jesus, that the healer, has been with us and raised our effort. We hope to continue to be the witness to the values and teaching and our Christ spirit. And more in Thailand, we have a small pantry in our church. This is including in the big help to the poor, the need one, include people with mental health illness.
During the COVID-19 pandemic, we are very concerned the people who have a problem of disability and overloading of caregivers of children with disabled. And so we, because in Taiwan, the COVID-19 infection is controlled in a very sensitive condition. So the social welfare is fully support as usual for the people who have such kind of problem can receive the support or the additional support to who need help. So I think like the McCain Memorial Hospital, we have a special section like the social workers and the psychologist department which they can provide some additional help to the person who asks for help. So we do our best to, as usual, to help those who need the help during this very straightforward situation.
right now, in order to ensure that there is adequate and expertise as well as human resource itself at the mission hospitals, there is some of the states have asked for training. For example, an MBBS doctor who can proceed to do more of obstetrics and gynecological work. So those kind of trainings are now being allowed by the government to ensure that these doctors, whoever is present in the mission hospitals, can address the needs of non-COVID related health issues that are coming to our hospitals. Because right now, all the government hospitals are the designated COVID hospitals. Our hospitals are mainly contributing and supporting the government in compensating it by looking at the non-COVID related issues. So in that regard, whichever human resources are available, we are trying to ensure that they are empowered and they have the capacity to handle every issue or health-related issue that comes. So the other way of getting HR is bringing about the motivation in the young and taking away this whole fear factor of serving in the mission, especially in this kind of a situation. So that is being done primarily by EMFI. I know there is a lot more to be done even from our end. The NCCI also tries to ensure that the candidates serve their bond. To getting human resource into the mission has been a challenge. There's no doubt about that. But whoever is there right now, we are building capacity. The other thing is the government is also pitching in with human resource because they are invoking the Epidemic Act and they can come and take over the hospital for a period of 90 days. So some have already come to our EHA hospitals and given about 12 doctors have been provided. So there are different equations that are happening to ensure that human resource within the hospitals is adequate. Regarding the finance and revenue, I've already spoken about it. It is mainly to do with insurance because there is no way for our mission hospitals to actually provide a safety net for their own right now, unless it just comes from their heart of giving. The best way to get that safety net is through the government and through the state, as well as the national insurance schemes. And that's where we are trying to pitch in for a broadening of those. And those are especially related to social issues when the migrant laborers are coming in. We do have a page to learn from the Kerala government who's got their act together. We have been having regional committee meetings with our regions, and we find that Kerala government our mission hospitals are relaxed over there because they know the government is taking care. So if that model can be applied to all the states, the issue of the social issues coming up with the migrants coming back home and assuring their safety and their well-being and their livelihood, it will be the government who will do it, and we will definitely push for that, either through our churches' help as well as with the mission hospital help, and of course through the Christian Coalition for Help.
Yeah, this is a very multifaceted kind of question, starting with what roles, if any, do lockdowns have to play in controlling the transmission of COVID, to how lockdowns are implemented in different countries and associated assault, if you may want to use that word, on freedom of movement and so on. So yeah, lockdowns, yes, as far as we know, as you know, this the whole area is something it's being developed in terms of what is the best way to respond to the COVID epidemic. Yes, lockdowns do have a role in as they say, flattening the curve by making sure that health services and social services and people in general not overwhelmed by a sudden rise in new infections of COVID, by making people stay at home, by restricting movements, restricting places and occasions where people gather, so that the infections that are coming up in a community are controlled, or in a way are only in such numbers which an existing health system can take care of. So that is the background and rationale for having these lockdowns. Now, lockdowns differ in different countries. We call some are total lockdowns, some are partial lockdowns, some are hard lockdowns, soft lockdowns. There are different ways that countries have been implementing lockdowns. We live in Thailand here, and what we see is the lockdown here can be called a soft lockdown. Thailand has achieved its immediate aims in terms of controlling the epidemic. Now the new infections are in single digits, and there is a progressive relaxation of lockdown. So this is Thailand. We also know about India, which is a very hard lockdown, and a lot of problems were caused for migrant labor and so on. And very often the bureaucracy takes charge, and there are often excesses in terms of how people are dealt with when they break lockdowns. So yes, so I would think it is in many ways how lockdowns are implemented are related to the heterogeneity of a country, homogeneity of a country. What kind of laws do people follow? Is there a civic sense, the degrees of civic sense, and so on? So it's very difficult to say that to propagate for one model of lockdown. I think countries know best that what lockdowns fits their circumstances, their context, their people, right? So part of the question is, when do gatherings like religious gatherings in churches, mosques and temples be permitted? I think that is the decision that had to be taken by countries who know their systems and people well.
While implementing the lockdowns, I think that there should be a very well coordinated balance, and the lockdowns should be implemented in accordance with the specific context of the countries. Of course, people shouldn't feel that they are restricted themselves, but people should understand that restrictions are necessary to their own benefits. And they should understand that it is much easier to prevent than to treat. And also it is very important in this difficult period to ensure that we don't overburden the hospitals, the clinics, the healthcare providers, because they don't have so much capacity to cope with so many cases.
There was a very hard lockdown in India, as mentioned by Salil. So that was a bit restricted, and also there was a lot of fear generated initially. So going out of the hospital was actually not done, but that didn't stop the hospital staff from sitting and packing medicines for each of their known patients in their database, because they knew their addresses. So they packed medicines worth enough for about a month, and they were sending it out through various ways. So that was being done. But now with the relaxation in the lockdown, almost 60% of our member institutions do have not just mobile clinics, but actual good outreach programs. There will be additional percentage who do the mobile clinics also. So they will definitely be going out, I'm sure they will be, and ensuring that they meet the needs of the rural areas especially. For the migrants in transit, I think I've already addressed that issue. But if there's any specific thing for the physically restricted and who are unable to reach the institutions, there is a talk going on about this whole telemedicine. The government has come up with its very clear guidelines for telemedicine practice. That is being now looked into very importantly by the by the group of lawyers to ensure that we are within our legal rights and we can do this whole telemedicine. And yes, Reverend Nasir is also asserting that the mobile clinics are in operation by many of the hospitals. So with the disability, yes, there's a lot of online counseling available with the doctors in the mission hospitals to address the needs of the caregivers as well as the patients who are restricted physically. Definitely a challenge, definitely something we need to work on more strategically, and I think we will look into that more seriously and have more webinars or something to ensure community participation is also done, because that's, I think, the first question, what is can be done other than what the government is doing in terms of restrictions. I think getting the community really involved will make a lot of difference in combating and stopping the spread of this virus and ensuring well-being for everybody in every area.
Well, the international human rights law, we know that guarantees everyone the right to the highest attainable standard of health, and also the governments have certain obligations. And then the human rights law also recognizes that in certain contexts, whenever there is a serious public health threats or issue happens, well, public emergencies, when threatening the life of the people, there are certain restrictions or measures can be applied too. And that can be justified when they have a legal basis for that. But today, what has been said or what has been to a certain extent accused by different human rights organizations in the world or civil society organizations and individuals, that governments across the world, they are rapidly expanding the use of digital surveillance. In that way, the human rights and human dignity of the people, that has been violated and negated. We know that technology can play an important, very important role in the global effort to combat the COVID-19 pandemic. However, this does not give governments some kind of a blank check to expand their authority, especially to expand the digital surveillance. But these days, the question is being raised about this digital surveillance in a different context. So increased digital surveillance to tackle this public health emergency, this has become a major concern of different organizations and different individuals in different parts of the world. At the same time, the concern has been raised that authorities cannot simply disregard the right to privacy and must ensure any new measures have robust human rights safeguards that should be protected everywhere. So wherever governments use the power of technology as part of their strategy, this is not only in China these days, in other Asian countries too, they use this technology to beat COVID-19. They must do in a proper way that respects human rights and human dignity of other individuals. So one thing is very clear, that violations of human rights that has been happening when or while they try to address these crises. Then we mentioned about the mental health issues, and so much prominence is given these days only to the physical health related issues. At the same time, mental health also has been reported from many contexts as a major issue, although some of them are not really infected or affected with this coronavirus. Well, it is in this context that the role of churches, especially the churches in Asia in different countries, although in some of the contexts they are microscopic minorities in Asia, of course, their contributions, their accompaniments Those are very much valued by governments and also the civil society and the secular bodies in different countries. So we will continue to accompany the vulnerable and those who are in need of Christian presence and Christian accompaniment at this kind of a situation, irrespective of our religious affiliations or faith affiliations. And that is why we are, or we have been engaged in this ministry for a long time. One thing all of us agree, that understanding health as a human right creates a legal obligation on states, but that is not the end of it. At the same time, wider societies do have responsibilities and their moral and ethical commitments that need to be ensured at every stage in order to protect the human rights and human dignity of each and every individual. So thank you very much for accepting our invitation to be part of this third webinar. CCA has initiated, as I mentioned in previous webinar sessions, that 6 webinars in this series in the context of the ongoing COVID-19 crisis. So we have panelists from diverse backgrounds to present their different views and perspectives during this session. 2 panelists from the UN system and also 5 others from different organizations, Christian hospital networks, churches, and civil society, church-related organizations too. So thank you very much for your time. And also several of the participants, those who have been participating throughout the session, I could recognize some of their faces, including my former colleague and friends, Dr. Dietrich Werner from Germany. Probably he got up very early morning to be part of it. And Mr. Leo from UK, and several others from different parts of Asia, including Australia and New Zealand. So although we are located at different time zones, you all demonstrated your keen interest to be part of this exercise, which is a humble initiative from our part. So let us continue this ongoing exercise, and we will be having 3 more webinars in coming days. The next one will be on 19th, and then on 21st, and then the last one will be on 28th of May. So the next one will be focusing on children, and after that on women, and the last one on food security. So you are most welcome to be part of all these webinars in coming weeks. Thank you for your being with us.